Now, this part is explaining the TB program itself, the TB workflow in general. I just wanted to ask you one thing, because my assumption is that whoever is going to be dealing with the development part may not have full understanding of how TB works. So let's understand what TB is. TB is a contagious disease. Happens mainly in lungs, which is called pulmonary TB, but also outside lungs, and that is called extrapulmonary TB. Now, the contagious TB is pulmonary, which you can spread. Now, there are basically 3 stages in any TB program. First one is screening, then there's diagnosis, and then there's treatment. Screening is when you you look for certain symptoms and identify whether this person who is being screened is in a risk group. By risk group, I mean a person who has the symptoms or a person who is in close contact with someone with TB. Because it's contagious, I mean, it's nothing like it's not a difficult concept to understand now, since we've all seen COVID. COVID was the same thing. You either have COVID or you have someone in your household or in close contacts who has COVID, which makes you a risk group, which makes you fall into the risk group. So if you are in close contact with anyone who has TB or is working in the TB domain, you can also catch it. Now, the first step is screening. Look for symptoms. If somebody has prolonged cough and productive cough, it has taken more than 2 weeks. If you have unexplained weight loss, or you have fever or night sweats, and these are all symptoms of TB, then you fall into the category of presumptive TB case, meaning it is presumed that you might have tuberculosis. So the outcome of screening phase is whether you are screened positive or not. If you have all these no's, meaning you are outside any risk group, and that's where your case is closed. If you are presumptive case, then second phase begins, which is diagnosis. Verifying that actually the symptoms you're telling about are a reflection of TB. It is actually TB or something else. So there are 2 different flows here. Some programs identify tuberculosis. Some program involve chest X-ray in the screening part. Some programs perform the X-rays after the screening. So X-ray is not part of the screening. Now, X-ray doesn't tell you everything about TB. You may have an abnormal chest X-ray and may not have TB. You may have an abnormal chest X-ray and may have TB. So chest X-ray doesn't tell you the full picture. A radiologist may look into chest X-ray and say, well, this is a presumptive TB case, in which case you will again be referred to diagnosis phase. Now, diagnosis is where your tests are performed. The first one is going to be sputum test. And basically, sputum is you can say the gold standard. Gold standard is actually culture test, but sputum test is pretty much what tells whether you have a TB or not, MTB bacteria or not. So there are certain tests recommended by WHO. Mainly, there's smear microscopy, which basically gives you MTB positive or MTB not detected or not detected, meaning in your sputum sample, does the microbiome, the TB bacteria exist or not, was it detected or not. This is smear microscopy. Then there's a gene expert test. It detects MTB as well as it tells you whether this, if there is a bacteria, whether this bacteria is resistant to rifampicin. Rifampicin is a drug used for treatment. So gene expert test tells you this. Then there's culture test. Culture test tells you a whole range of drugs against which the bacteria may be responding or not responding. So this all falls into diagnosis. All of the tests performed to identify that whether you have TB, or whether, if you have TB, what type of TB do you have. So you may have just MTB detective and no rif resistance detected, meaning you can be put on first line treatment. If you don't have even MTB detected, that means case closed, you don't have TB, you have something else, right? Now, if you do happen to have rif resistance, then that's a different type. But if you have rif susceptible, meaning that bacteria is responding to rifampicin, which means you will be put on first line treatment, which is the drug susceptible TB. You can say primitive type of TB, which can be easily treated. Now this is where your treatment begins. A person who has rif susceptible DSTB, drug susceptible TB, falls over here. So you're going to start your baseline treatment. First line regimen is going to be provided, and there's a 6-month duration on 2 HRZ. This is regimen, by the way. Or if you are eligible, you can go for 4-month long treatment. And there's an intensive phase where you after the incentive phase, all the basically the symptoms go away. So initial 2 months you feel very healthy, all the symptoms are now gone, and this is where a very high risk comes into place. As soon as the symptoms go away, many people under treatment stop taking medicine, meaning the treatment is not complete, only the symptoms went away, and now since they have stopped their medication, the TB is gonna come back and come back stronger. This time if they redevelop the symptoms, the same drugs may not be effective any longer. Now if you have completed your treatment, then again end of treatment, you will be tested. Okay, your treatment was completed and that's it, case closed. But if your treatment was not completed, or during the treatment if you were found resistant, then you move to drug resistant TB treatment. This is the second type of treatment. Basically there is drug susceptible TB, DSTB, stage 1, stage 2 is DR-TB, stage 3 is MDR-TB, stage 4 is XDR-TB. DR-TB is drug resistant TB, meaning your bacteria is resistant to only first line drugs. MDR-TB is multi-drug resistant TB, meaning there are multiple drugs against which that bacteria has developed resistance against. Then there's XDR-TB, that's an extreme case where only a handful of drugs are effective. Your bacteria is basically resistant to every other disease. XDR-TB is very uncommon, by the way, but it's very lethal too. It has high fatality rate as well. MDR-TB as compared to every other. Now, this whole program is the whole separate module was built for MDR-TB. DR-TB and MDR-TB you can think of pretty much the same thing, because the difference is only in the number of drugs that the bacteria is resistant against. So DR-TB one drug, the MDR-TB more than one drugs. Now all of these drug names you see, bedaquiline, fluoroquinolone, I always get this wrong. There's also delaminate, I'm missing that. These are all TB drugs, by the way, used for to treat DR-TB. If your resistance is confirmed, then your regimen is identified. Which group do you belong to? Which regimen are you going to be put on so that the treatment is effective? And if you look closely, this is forming a cycle. So you were diagnosed, you had DS-TB, it failed, you were diagnosed again, you had DR-TB failed or left incomplete, then again your treatment cycle continued, then again your treatment cycle continued. You can have many 5-6 treatment cycles before your treatment is ended. So in the same program, because of repetition of this cycle, this handling this data becomes challenging. It's obviously an oversimplification of how TB program works. There is a context behind every term you see. So for example, if you just wanted to if we just pick gene expert test, there's a whole detail about gene expert, how it's performed, what happens into that machine, what is MTB, what is RIF resistance, how it's detected, what is assay, what are cartridges, what are ultra cartridges. There's a whole, like, you can study for weeks this TB alone. But right now the objective is to give you a glimpse of what the TB treatment is looks like from a bird's eye view. Now afterwards, I have this complete end-to-end example, and this is a must read. This is a compulsory read. You cannot skip this. It's a story of an imaginary patient whose name is Jamal Karimov, and he's a 34-year-old taxi driver, and this guy is a patient in our system. There is another person, Aziza, who is a health worker responsible for collecting sputum sample, registering cases, and monitors dosages. Then a chest specialist, Rustam, Anwar, the radiologist, and another chest specialist, Ovis. Right? These people are providers. They are users. They have roles. They have privileges. The same thing we went through. Then there's the setting. Geographically, Khatlon is a region. Kolob is a sub-region within it, and a district, Vos, in Kolob has this hospital called Inter-District Hospital Vos. This is a facility where Jamal is going to be treated. Initially, Jamal gets treatment as an outpatient, but later he gets hospitalized, moved into Mashiton MDR-TB hospital. So this is the scenario, and you have to read this whole progression of Jamal from DS-TB, how he was screened, how he was diagnosed, what forms, what tables, what fields were used in the OpenMR system. It's all very important to understand. And what happens behind the scenes, the DOTS program, how that's running. Once he's confirmed, he is assigned a DOTS ID, and then he starts the treatment for 8 weeks. He's on DOTS. DOTS, by the way, stands for Directly Observed Therapy Short Course, meaning literally someone from your team, your health worker, is going to eyewitness the patient taking the medication. That's DOTS program. And after 2 months, Jamal traveled somewhere and stopped visiting. And while he stopped visiting, he also missed his doses. He was recorded as a lost to follow-up case, and the case was closed. But then he returns. 4 months after that, he returns with severe condition. He's lost weight. He's coughing blood now. Hemoptysis, the technical term for it, the medical term. He was previously treated first line drugs, and now he has developed resistance. So he gets enrolled again, and again during the treatment his regimen changes because the treatment is no longer effective, and then he is referred to another one. He's referred to Oves, who is taking over the case now. And then for yet another time, another cycle of treatment starts. Third time he is enrolled into the MDR-TB program, and this time he completes the treatment and turns out to be cured as the outcome of the whole TB treatment. So this is not what I'm calling as a story is not a story. Basically, you will read every word of it and understand the entities, the tables, the values, the terms that are involved. Without this understanding, it will be a big risk, a major risk to work on this TB system. You see, there's a background of why we are in this current state. There aren't many people who are savvy in Java, first of all, and in Java too there aren't many people who are in healthcare. Now even if you know Java and even if you are in healthcare, understanding and working on a TB system requires thorough domain knowledge, and I have tried my best to keep the reading material as little as possible. I cannot think of a way to shorten it further. This is something which is not like an optional thing. The guy I'm gonna hire is going to also go through the same process, just the way we did. I still remember we used to have this training program. First of all, TB specialists used to come and explain the whole day workshop just on explaining TB. We also had these field visits to understand the disease better, to be able to make the accurate decisions during the programming and development.